female of 55 years old. She presented an acute pancreatitis in 2012. A CT scan shows a cystic lesion of 12 millimeter in the tail. Pseudocyst is suspect at this moment. No stone was found after cholecystectomy, and the recurrence of acute pancreatitis happened in 2014. MRCP show a pancreas divisum, and the sphincterotomy of the minor papilla was performed at this moment. However, cystic lesion of the tail increased in size and measure 20 millimeter in 2015. So it's decided to perform a EUS with confocal microscopy. We can join Dr. Iglesias and Kyle in room 3.
We are just in the way to intubate the patient.
So we have mucinous, pseudocyst, or maybe IPMN.
Yeah, that's probably the most differential diagnosis for the cystic lesion. So now we're just trying to go directly to for the evaluation of the lesion, because I think we are just on time. Anyhow, whenever you're going to evaluate any kind of cystic lesion, it's very, very important to take a look at the pancreatic parenchyma, because it's all going to provide you a lot of information regarding the probable diagnosis. So if you find a patient with some data of chronic pancreatitis, of course, that should try to exclude more the presence of a pseudocyst. But if you have a normal pancreatic parenchyma, probably you should better think in a mucinous lesion mainly. So now we're in the left kidney, so we have really the pancreas in the top of the images, and here we have the lesion. So this is for sure not a pseudocyst, because it's not the typical appearance. It's more appearance of a
pseudocyst maybe, or
yeah,
IPMN.
Or IPMN. Okay. So the lesion is located more than in the tail, more yes, to the body of the pancreas. Here we have. Okay, so now, if we want to show, we can. We see that the pancreatic parenchyma surrounding it's quite normal, mainly in a patient that has past acute pancreatitis, so it's not clearly signs of chronic pancreatitis. So probably this is more like to be a cystic tumor, and I think this is we just can measure
what
the
do you
size.
Think, IPMN or pseudocyst?
That's a good question.
Because
okay.
The vessel will stop. Okay.
Okay, we will measure, and I think
yes,
the best thing is to try to sample and make the confocal.
Yeah.
So we will go directly to the confocal.
Yes, because we have not a lot of time. Oh. Because we are hungry.
We could have, while we're waiting, could we have a vote from the audience about the type of cyst? So those voting for IPMN? How do you think? And possibly a serous cystadenoma?
I'm expecting a 50-50.
It's approximately that. Yeah, I'll be fair, yes.
We check.
Anybody still think it might be a pseudocyst? No, so that's gone.
Oh, I will show you. Wait, I will show you the probe, the preloaded probe. Okay, it's okay. The probe is here at the top of the needle. Of course, now it's like a classical punction.
Yes, I need to thank Fabrice, because I'm not so used, yes, to make the FNA, but not so used to the system. So we will just go for a standard, and we're using the 19 gauge needle from Cook that he has preloaded the system. But for the puncture, it just works the same as a standard needle.
Yes, it's the same.
It's exactly the same, so we will just take the lesion into position. As always, we will try to check for vessels, just to avoid any kind of complication, and I think we are quite safe. Okay, so now we are going to place the needle in position, and we go for the puncture. So
yes,
okay.
you're in.
We are inside of the lesion, and now I need the help of Fabrice to
yes.
show you exactly
will-
how this works.
We will.
You can see in the
probe is
EUS
out.
imaging the tip of the probe, of the Cellvitrio probe. I think this is the tip.
We have injected fluorescein, and so you have to go against the wall. You are. Maybe the probe is not out.
No, I think the probe is just...
Yes, the probe is out. But the fluorescein is not totally in the blood. Ah, it's coming. Images are coming. I think I saw Papilla, but I'm not.
Okay, here you need to learn to be a pathologist more than an endosonographer also. It's another type of black and white imaging.
Yes, donc in white it's vessels, so you have to move just a bit against the wall.
So I just press, okay.
Very nice.
Okay.
Not to just remove.
Okay.
Perfect. We are waiting for fluorescein. We still. Huh?
I found it really complex to understand the image. And what is the learning curve, Fabrice, to be able to really make a good study from the confocal?
I think it's quite easy if you see a lot of videos
Okay.
without a punction. The problem is with the punction. For the moment, we didn't see anything. We are waiting. No, I think, yes, I think it's pancreas.
I'm trying to change to...
Yes, that's good. We are.
Le flux n'est pas tout passé.
No,
We should wait. It's a Cerus.
maybe in
Yes, it's a
fact.
Cerus now. No, it's a Cerus. No, it's a Cerus.
Yes. You
You should
yes.
wait because the fluorescence
Yes,
now
yes. You
is-
see all the vessels?
Okay.
It's
It's
a
a,
network of vessels.
it's like
Yes.
network.
It's a network of vessels. This is typical of Cerus cystadenoma.
Huh?
Yeah.
This is 100% of specificity. This
Okay.
is the,
How many people lost in the room?
this is typical
This is
we
one
are,
of...
we are just waiting a bit, but
because we should wait. that-
try to move a bit.
Yeah.
It's very good, huh?
And this is one of the most important differential diagnosis of a lesion
Yeah,
to, to differentiate. This is oligocystic serous cystadenoma. So this is very important to see because there is nothing to, this is just follow up.
I'm sure many people thought it was IPMN. And it's
Okay?
okay. I just
And this voilà. Encore.
we saw it very nice once.
This is not so bad.
It's very interesting how the endosonographers are moving from different types of what black and white images.
Push a
No.
little bit
Yeah,
the-
sure.
The probe.
Okay?
We are waiting for the good image, huh? But we saw it. Huh?
Maybe if you change the the position of the needle, yes, like this.
Yeah.
Yes, 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 yes. Yes. Yes.
Wow.
This is this is this is
Ah.
typical, yes.
There's
This
a-
is the
There's a lot of vessels in different direction.
So this is the typical aspect of a pseudocystadnoma?
Zero cyst here.
Okay.
Here. So we will remove the.
Do you want to aspirate?
We will
I'm
remove
not
the.
going to ask the show of hands, okay? I'm not going to do that.
5 minutes. Less.
Oh la la. We
Yeah,
will
we will
finish.
just obtain some liquid from the lesion also.
Yes, the patient is included in a study. And in the study, we have, of course, need all what we can for the diagnosis.
It's almost disappeared with the aspiration.
Maybe
So, but
maybe we have liquid in the needle. Huh? We can try.
yeah,
but the image is in favor of Procerus.
well, if not,
we
we
will
can
try. We will try. So we will stop the procedure. We will see what we have in the needle.